Hi, I'm Dr. Brian Koffman, a retired family doctor and a CLL patient myself, and the Chief Medical Officer, Executive Vice President of the nonprofit CLL Society, and I'm excited to be back live at ASH 2022. Dr. Kay?
Hi, I'm Neil Kay, and I'm a hematologist at Mayo Clinic in Rochester. I'm also excited to be here at ASH this year and to be with my dear friend Brian Koffman.
Neil, you and I attended the first oral session, and the oral sessions are not arguably, are clearly what the Society of Hematologists say. These are the most important papers. These are what doctors, you really got to pay attention to this. And every single paper that we heard was a doublet, a combination. So could you talk to us a little bit, just explain what those combinations were, and then maybe we can get into why they're important, what's good about the trials, what's not so good about the trials, because this seems to be the direction the research is going in.
Yes, exactly, and I'm happy to define potentially why we're using doublets, and that is primarily because there appears to be alternative mechanisms of action, if you will, where the BTKIs are allowing the CLL.
So the BTKIs are ibrutinib, acalabrutinib, and zanubrutinib, hopefully soon.
Which will be hopefully soon. Yeah. And they're mobilizing these cells so that they're not stuck in the bone marrow lymph node. They're available potentially to be exposed to drugs. And the drug venetoclax, which really blunts BCL2 activity, which is a key anti-apoptotic molecule in CLL.
So explain anti-apoptotic to us.
That's a particular protein that prevents the cell from dying. And if it's gone, that's a good thing in that the CLL cell will most likely be killed. So simplistically, it's two different mechanisms of action with two agents.
We talk about these orthogonal or right angle approaches because they're coming at the cancer in two different ways.
Right, exactly. And we know that individually these agents do have activity in CLL, but to put them together gives the possibility of additive or synergistic activity, which of course would be a potentially great benefit to a CLL patient.
So I don't want to oversimplify things, but talk to us a little bit about the combinations that were discussed and why they particularly made sense, and and what the data showed and what the data didn't show, or what you would also like to see as a clinician and a researcher.
Yeah, that's a complicated question because there was a lot shown at this session, and clearly there was a lot of work done on these trials. The Captivate, the GLOW, the long-term follow-ups from MD Anderson with the doublets. The primary data that was presented was consistently showing that the doublet, the ibrutinib plus venetoclax, could effectively induce clinical remissions in most patients, and that remission would likely last for a very long period of time, although we have to remember these studies are still early in follow-up. The other aspect that it showed was that minimal residual disease, probably detected by a variety of different approaches, was able to be reduced, this minimal residual disease, to a level that we now call undetectable. There are there's controversy about what is the right level to get a patient to, but these minimal residual disease levels were reached in both blood and bone marrow, and that seems to, in general, predict for a very good outcome for progression-free survivorship, at least.
So all of that sounds pretty positive. Was there a toxicity side or a negative side? And we're generalizing. We heard 6 different papers with different combinations in frontline and relapsed refractory. So I know this is kind of a general overview, and I'm going to be interviewing some of the investigators, I think most of the investigators, on their individual trials. But I'm just looking kind of your overview in terms of how you see this movement fitting in. We heard about the good sides, and the numbers were not 80s, 90% of progression-free survival, overall survival. I mean, very impressive data with a significant length of time. But the concern is I'm putting all my eggs in one basket. What powder do I have left if I use it all up at front? These are the concerns I have. What did you see as there that concerned you about increased toxicity or other issues?
Well, I didn't, from toxicity standpoint, I actually did not hear any alarm signs, any warning bells. There still was reports of diarrhea persisting and atrial fibrillation, hypertension, but it looked like it was diminishing over time. But for these trials, again, these are still relatively early in follow-up, and we need to see much more prolonged follow-up. What did concern me was primarily two things. One was the application of doublets up front to CLL patients. There was one abstract, the last one, which was presented by Philip Thompson, where these were high-risk CLL patients who were on ibrutinib and then looked like they would need another drug and went on to venetoclax. But in the other protocols, these were doublets given pretty much up front to the two patients, and then in a time-limited manner. So what concerned me was, do we really need to be doing this in all CLL patients, or should this be a subset of patients who perhaps are younger, who want time-limited therapy and have high-risk features?
So I did also notice that there seemed to be very little differentiation with these studies between how well you did based on your prognostic markers, which is quite different than what we've seen before. The 17Ps generally did as well, the TP53s. In several cases, the unmutated, which is usually a poor prognostic marker, did it just as well or even slightly better than the mutated. So help me understand that a little.
Yeah, and we need to unravel this. It was confusing, and it made me concerned about aspects of use. We do know these prognostic markers are very reliable and accurately predict for time to first treatment. They likely, as a group, would also predict for effective response to therapies. Yet in this set of presentations, it appeared that unmutated IgHV would have which is an unfavorable genetic mutation, particularly in combination with P53, had higher levels of undetectable MRD, and they did better. And we need to unravel that. One other aspect that I think wasn't addressed as thoroughly as I would like was what was the methodology for the MRD and what was the timing of the MRD. We need to be consistent and agree upon how we detect these and when we detect them and what methodologies. And it's a little, to me, like the Wild West. So while I think the clinical results right now are pretty impressive, I worry that we are not developing a coherent way of evaluating patients on doublets. And how do we use the classic clinical approach, history, physical, imaging, blood work, in tandem with MRD levels? And to me, this is an area of great controversy. It's very early, and I worry that we're rushing to judgment on the value of doublets based more on MRD in a way than anything else.
Any final thoughts you want to share with patients about these combinations? Because there's been so much excitement about them over the last few years, and it seems to be even at more of a fever pitch here.
Absolutely. I think there's clearly going to be room for doublets. My guess is that it would be for young patients who can tolerate doublets, who don't get all the toxicities, perhaps, or can deal with them better because they are young, and who have high risk. And right now, the high risks that we know, we can quantify those. We know it's P53, we know it's complex karyotype, we know about the unmutated. So I believe there clearly will be space for using doublet therapy where it's appropriate to be using these up front in a specific category and for a time-limited approach. Those are meritorious things, and ultimately we will get there, hopefully in a coherent way.
Dr. K, I always learn something sitting down with you. Thanks so much.
My pleasure.